Hello everyone and welcome to our webinar entitled ECMO for Severe ARDS Associated with COVID-19. This event is brought to you by the National Kidney and Transplant Institute in cooperation with ECMO Phil, an association of ECMO practitioners in the Philippines. I'm Dr. Joanne Kathleen Jinete Garcia, the moderator for today's webinar. Just a little housekeeping before we get started. Your speakers and videos will be disabled throughout the duration of this webinar. If you have questions during the presentation, please type them into the Q&A box in your Zoom control panel. We will have time for questions at the end of the presentation. Also, we would like to hear your feedback. You will be directed to an evaluation form at the end of this webinar. Once you have completed the feedback form, we will be sending your certificate of attendance through email. So this will be the flow of our discussion today. Moving on, just a quick background. We are all aware that our lives have changed since the start of the pandemic. Globally, as of August 31, there have been more than 25 million confirmed cases of COVID-19, including more than 800,000 deaths reported to WHO. The Philippines on August 6 surpassed Indonesia for the most reported cases in Southeast Asia. Since the government lifted most restrictions in June, a new surge in cases have overwhelmed the public health system and further damaged the economy. More deaths, including those of healthcare workers, were recorded. And as a third world country, there's a limit to what we can do to save our patients. The most dreaded complication, acute respiratory distress syndrome, or ARDS, has claimed many lives. But in some developed countries, outcome of patients who underwent ECMO seems to be promising. Only several hospitals in the Philippines have ECMO machines, and to date, we have limited experience on the practice of ECMO in COVID-19. In addition to the ample supply of resources and manpower that our country needs, we have so much more to learn and understand. That is why we are very fortunate today to have with us an esteemed doctor, professor, ECMO expert, and researcher. So that we can move forward and go into our content, I would like to call on our ECMO Program Director, the Deputy Executive Director of the National Kidney and Transplant Institute, Dr. Joselito R. Chavez, to formally welcome and introduce our guest speaker.
Good morning to our speaker in Paris, and good afternoon to our participants in the Philippines. On behalf of the management of the National Kidney and Transplant Institute, and the members of the ECMO Philippines group, I would like to welcome our distinguished speaker and our participants to this webinar. At this time of the pandemic, experts from all over the world have been in continuous search for the magic bullet to address the COVID-19 disease in order to save lives. Various therapies and management strategies have been tried and studied in many centers internationally, and for the first time, we see a widespread free sharing of information and knowledge across borders to address the problem. Today, we are a fortunate group to hear from a world-renowned authority on extracorporeal membrane oxygenation, or ECMO, and its use in ARDS associated with COVID-19. The use of ECMO has increased since the time of H1N1, when it showed great promise in improving mortality among those seriously afflicted with a viral infection. During this global pandemic, we ask, what is the role of ECMO? How can we use the technology to help us manage COVID-19? In the recent years, we have seen many of our centers in the Philippines use ECMO for cardiorespiratory support, ARDS, severe pneumonia, and pulmonary hemorrhage, to name a few. Indeed, the time of ECMO has come to the Philippines, and we need to learn more of the technology. We are extremely grateful to our speaker for joining us today, direct from Paris, to share with us his experience on the use of ECMO in COVID-19. Our distinguished speaker is an assistant professor of intensive care medicine at Sorbonne University, considered the second oldest university in Europe. And he is a senior intensivist at the Medical Intensive Care Petit-Salpêtrière Hospital, also in Paris. His research interests span the fields of cardiogenic shock, mechanical circulatory assistance, reserved therapies for severe ARDS, including ECMO and mechanical ventilation. He is the investigator for multiple ongoing studies, including randomized controlled trials in the field of ECMO, and is the author of more than 140 scientific publications and numerous book chapters. He is the chair of the scientific committee of the Euro-ELSO. Our speaker is the main author of the respiratory ECMO survival predictor score that is used worldwide in predicting survival after ECMO for severe acute respiratory failure. Dear colleagues, with much pride, may I present to you Professor Matthieu Schmidt.
Thank you very much for this kind introduction. Good afternoon, everyone. I'm very pleased to be there with you today to discuss about ECMO for severe ARDS and more specifically ECMO for COVID-19. So I will share my screen. Yep. So yes, in last April, we have been massively hit by the COVID-19 outbreak. And during the high season of COVID-19, France, the number of ICU beds peaked at 7,500 ICU beds. So clearly it was a very tough period. And during that time, with a number of ARDS patients, we managed a few of them with ECMO, and I will remind you, during the first slide, I will remind you what is ECMO for severe ARDS, what are the main indications, and I will especially focus my talk on COVID-19 to relate you our experience in my center with quite a large number of COVID-19 patients, and to show you, to try to stress out what are the main differences in the management between COVID-19 patients and other ARDS patients. So first of all, just a few reminders about the indication of VV ECMO, because we are dealing with the most severe patient, and if you want that technique being efficient, you need to pick up the right patient and to pick the patient who are more likely to survive, to benefit from this technique. So clearly ECMO is for the most severe patients, the most severe ARDS, and what is important is that before using ECMO, you need to have tried at least to ventilate properly your patient, so meaning using low tidal volume, to have a control of the plateau pressure, to use IPEEP. This patient will frequently have neuromuscular blockade, and prone positioning try is almost mandatory. It's highly recommended to try prone positioning before thinking about ECMO, because all these simple maneuvers have shown benefit in terms of outcome, and also they are quite easy to apply. They are not so invasive, and they can be done everywhere. So my first key message is to think about ECMO when you have already tried all these maneuvers, and when these maneuvers fail, then you can think about ECMO. So ECMO, the first function of ECMO is obviously to replace pulmonary function, to allow the lung to rest. So we will see in a couple of slides, we will see that one of the key functions is to rest the lung, so to stop, to reduce mechanical ventilation injuries on the lung, so to markedly decrease the intensity of mechanical ventilation, because oxygen supply and carbon dioxide removal is ensured by the ECMO, and to wait for sometimes a very long time to allow to wait the healing of the lungs. So I will not review all the literatures about VV ECMO use in severe ARDS, but I will just focus on the last very important trial, which has helped to better define what is the place of ECMO in the severe ARDS management. So this is the EOLIA trial. So the EOLIA trial was designed to determine the effect of early initiation of ECMO in patients with the most severe form of ARDS. And the inclusion criteria were patient intubated and on mechanical ventilation for less than 7 days. These patients should have been optimized before inclusion, meaning that they all received protected ventilation with a low tidal volume of 6 ml per kilogram predicted body weight. They have a PEEP trial, and they had a PEEP level above 10 centimeters of water, and they had a FiO2 above 80%. So the inclusion criteria were one of the 3 following disease severity criteria, and these criteria are quite important because actually to date they are the gold indication for VV ECMO, and we daily use this criteria to see if the patient will be a good candidate for ECMO. So the first criteria was what we can call a rapid and very severe acute hypoxemia with a PaO2 and FiO2 ratio lower than 50 for more than 3 hours, despite having used other adjuvant maneuvers, including prone positioning. The second criteria is a PF ratio lower than 80 for more than 6 hours, despite similar criteria. And the third criteria is profound respiratory acidosis for more than 6 hours, despite an increase of the respiratory rate. So these 3 criteria are quite important, very important, because we use it in our daily practice. It's not only criteria for RCT, it's what we do in our clinical practice. What was interesting, but what was also complicated in that trial is that for obvious ethical reason, we needed to have to settle a rescue ECMO for the control group, meaning that if the patient has been allocated to the control group, if he had a very profound hypoxemia, we didn't let the patient dying, and we switched the patient into ECMO. This is what is called rescue ECMO for the control group, but we previously defined some these criteria. So this patient should have a refractory hypoxemia defined by a saturation below 80% for more than 6 hours. So clearly very, very sick patient, almost dying patient, despite mandatory trial of all these maneuvers, prone positioning, recruitment maneuvers, inhalated prostacyclin, nitric oxide, and obviously the treating physician should be quite convinced that ECMO might change the prognosis of this patient from the control group. So these are the results that probably most of you already know. So we got 124 patients randomized into the interventional arm, so they received ECMO. On the other end, we have 125 patients in the control group, but what you can already notice is that 35 patients from the control group received at the end ECMO because they were rescued by ECMO for a very profound hypoxemia. And this will complicate a little bit the interpretation of the result of the EOLIA trial. So the primary endpoint was in intention to treat. And as you see, from a statistical perspective, this trial was negative because it didn't reach the gold number 0.005. And you see that it was quite close, but not enough to be statistically significant. And when you compare the control group versus the ECMO group, you have 46% mortality in the control group, 35% in the ECMO group. You see that the two curves are quite, there are space between the two curves. They are very different, but not enough to reach significativity. What was interesting is a secondary endpoint. And the secondary endpoint was to say that we will compare deaths inside the ECMO group versus deaths or crossover to ECMO in control patient, meaning that we consider that these 35 patients who received ECMO, despite being in the control group, they received ECMO as a rescue, so they were probably died, they would have died if ECMO was not performed. And if you look at this secondary endpoint, you see that the mortality is very different. We have 35% mortality in the ECMO group versus 57% mortality in the control group with significativity. What is interesting to see is that ECMO is not limited to pulmonary support. You see that it will also impact the hemodynamic of the patient, even if it's a VV ECMO. With ECMO, it will allow to markedly decrease the vasopressor used. You will have more days alive and free of cardiac failure, more days alive and free of dialysis, less days with renal failure, less days with prone positioning, and more days alive and free of nitric oxide. So clearly, what was new in that trial is that ECMO is efficient beyond only pulmonary support, and you have an improvement of many other extrapulmonary factors. So what about the timing? The timing is essential. It's very important. You need to have, we already know from previous quite old studies that clearly the prognosis is not the same if ECMO has been performed after more than 7 days on mechanical ventilation. You see that the odds ratio is much higher compared to a patient who received ECMO before 7 days of mechanical ventilation. So it's important. This is another study that we published a couple of years ago, but you can clearly see that the prognosis is not the same if the patient has been cannulated early on, meaning with less than 3 days of mechanical ventilation versus more than 10 days of mechanical ventilation before ECMO. You see that the prognosis is very different. So clearly the timing will impact the outcome. And if you look at from a physiological perspective, you see that if you look at histological lesion of ARDS patient, you see that after 7 days, you start to have fibrosis. You have fibrosis lesions inside the lung, in the lung, and this is probably the main reason why ECMO is not so efficient. Obviously, we do it sometimes, but it's much better to put the ECMO at that time when fibrosis is not there, rather than starting ECMO later on when you have already fibrosis lesions. And if we look at, if we compare the mortality of the crossover, meaning the patient were allocated to the control group and who received ECMO as the rescue therapy, so meaning when they were almost dying, you see that these patients were very, very severe, and 35 patients received ECMO as a rescue therapy. You see that they had a higher plateau pressure compared to the ECMO group. They had a higher driving pressure, they have a lower respiratory system compliance, they have an involvement of more cadent on the chest X-ray. And you see that or sick, there were 9 patients has been cannulated. 9 patients had a cardiac arrest before cannulation, 7 had a severe right heart failure, 11 developed renal failure requiring dialysis. We even we used veno-arterial ECMO to 7 patients because 6 of them were cannulated on CPR. So they were very severe. And when you compare the mortality of this crossover, so meaning patients who are cannulated very late compared to the ECMO group, you have 57% mortality versus 35% mortality in the ECMO group. So clearly the timing is very important. And if you cannulate too late your patient, it will clearly impact the outcome. So clearly one of the probably most difficult things in with ECMO is to know who are the patients who are more likely to benefit from this technique, from this invasive, costly techniques. So patient selection is important. If you look at the subgroup analysis of the earlier trial, you see that patients who benefit from ECMO are not the patients who are the most hypoxemic. If you look at the PF ratio above 66, you see that the benefit seems to be for that subgroup. So meaning that when the patient is very, very, very hypoxemic, maybe ECMO is mandatory to use, but maybe it's not the best subgroup to benefit, which will benefit from ECMO. Same when you have a lactate above 2, when your patient have extra pulmonary impairment, when you have hemodynamic failure, for example, when you have a lactate above 2, you see that probably the mortality is probably higher in this patient. Clearly for patients who are very sick with a high SOFA score, they probably will not benefit so much. So clearly the timing will import, and if we compare which criteria benefit most, you see that the criteria 3, so the patient were cannulated for severe respiratory acidosis, this patient seems to benefit most from ECMO, even if it's quite small number, so it's quite difficult to raise a formal conclusion from that, but it will just tell you that when you have a very severe compliance impairment, and when the patient have a very severe respiratory acidosis, it might be benefit to use ECMO. Another way to try to select your patient and to allocate ECMO for patients who are more likely to benefit from this technique is to use some predictive survival model. So this is just an example of easy tools that you can get on your smartphone with this web link, www.redscore.com. So it will you just have to tick the characteristic of your pre-ECMO patient, the pre-ECMO characteristic of your patient, and it will give you estimated survival of your patient if you put the ECMO on. Obviously, it's not a magic bullet. It will never be a substitute for clinical judgment, but it could be an additional tool for a clinician at the bedside. So this is what we do in our daily practice. We clearly apply the Eolia criteria. So this is a well-designed algorithm that we published in an editorial last year. So if the patient has a PF ratio below 150, clearly we strongly recommend prone positioning, neuromuscular blockade, IPIP strategy, and to try to avoid using ECMO. And if this patient, despite this treatment, have one of these 3 Eolia criteria, you have to ask yourself, is there any contraindication to ECMO? If not, we recommend using ECMO. And in case the PF ratio is above 150, if you have issue with decarboxylation with a profound acidosis, despite increasing your respiratory rate, it might be also an indication for ECMO. So clearly we apply Eolia criteria. We use ECMO for a very severe form of ARDS when you have impaired gas exchange despite the use of conventional strategies. What is interesting and what is very important when you deal with severe ARDS on ECMO is to rest the lung, and for that we use early ultra-protective ventilation. So we markedly decreased the driving pressure, so the difference between the plateau pressure and the PEEP. We decrease the tidal volume, we decrease the plateau pressure to rest the lung and to wait for the healing of the lung. The target on ECMO is to target a driving pressure below 15 centimeters of water. And this is clearly what it is done in most of the large case volume centers in the world. This is based on a large cohort that we recently published. You see that if you look at the tidal volume before ECMO, it was before ECMO, very few patients had a very low tidal volume, but you see after, during the first 2 days on ECMO, most of the patients had a tidal volume below 4 ml per kilogram. Same for the driving pressure, the target on ECMO, so on the blue line, you see that most of the center used a low driving pressure. So clearly, your patient should have a driving pressure below 15 and a tidal volume lower than 4 ml per kilogram. This is done to decrease the mechanical power, so it's done to decrease the energy transmitted by mechanical ventilation into the lungs, so to decrease, to stop, to at least to enhance lung protection. And for that, we decrease the respiratory rate, we decrease the tidal volumes, and we decrease the plateau pressure. And we increase a little bit the PEEP to maintain a certain level of recruitment. So this was done in the 2 randomized control trial in that field, with a respiratory rate, a lower respiratory rate on ECMO, a lower plateau pressure, a PEEP above 10, decrease the FiO2, and decrease the tidal volume. So after these reminders, if we focus on ECMO for COVID-19, it was, if you look at the previous months, we were surprised. We looked with great attention all the cohort, especially cohort coming from Italy. Italy was hit by the COVID-19 outbreak roughly 1 month, 1.5 months before us. So they published early on in the JAMA a large cohort of COVID-19 patients in the Lombardy region. This team, all this Lombardy team are very famous. They are well known for ECMO management. You see some well-known name in the authors. And we were quite surprised that the number of ECMO at that stage, at that early on in the pandemic, was quite low. Less than 1% of these patients were on ECMO, despite a very high severity, because 88% of them require endotracheal intubation. You see the level of PEEP of this patient, which provide you, which give you an idea of the severity of this patient. And clearly, at the beginning of the pandemic, there was a mistrust regarding ECMO for obvious reason. We were facing to a new disease with unknown outcome. Our health system and all the health system in Europe were rapidly overwhelmed with scarce resource in times of high demands. And I think clearly most of the physicians
were fear of bed blockers, because we know that ECMO patients, we expect a long ICU stay. We expect a long ICU stay, long ECMO run with clearly at the beginning unknown outcome for this patient. So probably most of the physicians were fear of bed blockers in the context when ICU beds were already lacking. Another explanation for mistrust regarding ECMO is that at the beginning of the pandemic, lots of anecdotal evidence, personal viewpoint, and have been largely diffused on social media. And just to show you, for example, an editorial published in the Lancet Respiratory saying that we should be very cautious using ECMO for COVID-19 because ECMO was associated with an increase of the inflammatory markers, especially an increase of the 6 interleukin, which is deeply involved in the COVID-19 disease. This editorial stress out that probably maybe ECMO is not very suitable for this patient, but this is only a viewpoint. This is not based on any clinical scientific evidence, and clearly we haven't seen that it was an issue on ECMO, and we more frequently see that most of the patients are rapidly stabilized on ECMO rather than being highly inflammatory and highly unstabilized. Another anecdotal evidence that was shared on social media is that coming from China, there were a fear of SARS-CoV-2 scavenging inside the ECMO membrane. So some report, mainly on social media, not on scientific publication, say that maybe SARS-CoV-2, the virus is so small that the virus can spread inside the ECMO membrane and can diffuse through the gas outlet into the room with obvious risk for healthcare givers and a very high risk of aerosolization of the room. So based on that, we wanted to demonstrate if it was true or false. And for that, we analyzed in 27 patients, ECMO patients, we analyzed the gas outlet of the membrane. And we look at if we found any virus in this patient. And as you see, 25 patients had positive samples, and most of them, half of them were viremic, so with a very high load, high virus load, and we never found SARS-CoV-2 in the exhalation port of the ECMO membrane. So clearly, it maybe it happens once in China or twice in few cases, but clearly it is not frequent, and it should not refrain yourself to use ECMO for COVID-19 patients. But at the beginning, it was one of the sources of the mistrust regarding ECMO. Another reason for mistrust regarding ECMO at the beginning of the pandemic was the initial alarm about the outcomes. Clearly, the COVID-19 outbreak hit China months before us, and they early on they report poor outcome in very small case series from China. So we can ask yourself about what were the experience of this center. I don't have the answer of that, but if you look at this report, they did a pool analysis of early reports of ECMO used in COVID-19. You see that 0% survivors, 0% survivors in that study, and at the end you end up with 94% mortality. And clearly, not a good signal at the beginning for using ECMO in a COVID-19 patient. But what we did in my center, we continue to use ECMO because it's clearly we are experienced in that technique, and also because most of these patients couldn't be improved by usual rescue maneuvers. And we report recently the outcome of 83 patients from our centers. And clearly in that period when most of the health system are overwhelmed, you need and you want to delay a little bit ECMO, and you want to be sure that you have tried everything before getting on ECMO for this patient. So for that, we had a very strict application of the earlier criteria because we were running out of ICU beds. It was tricky to find beds for this patient. So clearly we wanted to be sure that this patient we are likely to benefit from the technique. And for that, we select only patient with younger than 70 years old, intubated for less than 7 days. Prone positioning was highly recommended, even it was mandatory. And we apply one, if the patient meet one of the 3 earlier criteria, he will qualify for VV ECMO. So this is the patient. As you see, very young patient, 49 years old, median age, mostly male patient, but it was well described in COVID-19 that it frequently hit a male. Patient in overweight, you see that the BMI was in median at 30. This patient has comorbidities, hypertension, diabetes. And you see that the patient were cannulated after 4 days of mechanical ventilation. And most of these patients were retrieved from other ICU with our mobile ECMO team. This is the ventilation parameters before ECMO. You see how sick they were, all ventilated with 100% FiO2, very high level of PEEP, low tidal volume at 6, respiratory rate at the upper limit of 29. The plateau pressure was reaching 32. So clearly they were well ventilated, but they were ventilated at the maximum. You see the blood gas before ECMO. You see how low was the pH, 60 PF ratio in medium. The PCO2 was high with a low pH. And what is interesting is to see that we clearly apply rescue therapy before ECMO, and you see the very large number of patients who receive prone positioning before getting on ECMO. 96% of them receive neuromuscular blockade. So clearly, we try to avoid using ECMO by doing what can be done everywhere, like use of neuromuscular blockades or prone positioning. If this rescue therapy failed, then we went for ECMO. And this is our result. Clearly, when you do ECMO study, you need to have a long follow-up because, as you can see, if you stop at day 28, you will lose lots of information after it. And you have clearly, you will have a wrong explanation, you will have a wrong interpretation of your result. So what is interesting to see is that in red, you have the dying people who died in ICU. These are the patients who are on ECMO. You see that the number of patients on ECMO decrease day after day. And this is what we want to see. We want to see green, lots of green, meaning that the patients are alive and out of ICU. And at the end, when you look at our results, you see that at day 60, you have 31% mortality and you have 45% of your patients who are alive and out of ICU. But you see also that 6% of these patients are still on ECMO at day 60. So you need to expect long ECMO run to be very patient and not to conclude too early that the patient will never improve. And at day 60, 18% of them are still in ICU, even if they were weaned off ECMO. So at day 90, less patients obviously are still in the ICU, only 6%. But you see that it's probably the final mortality of this patient is 36%, with 56% of them alive and out of ICU. So what is interesting is to compare what is different between COVID-19 management, the management of COVID-19 patient on ECMO compared to the EOLIA trial. So I will stress out what are the main differences, and this difference will explain why how we manage these patients. So if we compare the COVID-19 patient versus the ECMO group in the EOLIA trial, you see that the delay between ICU admission to ECMO was much higher for the COVID-19 ECMO patient. Clearly, the main explanation is that we try to avoid using ECMO by using all rescue strategy available, including prone positioning, neuromuscular blockade. So obviously, it will delay a little bit. It will increase the time between ICU admission and ECMO cannulation. You see that these patients were probably sicker with a lower PF ratio compared to the ECMO, the EOLIA control group. What is interesting is that we strived to use prone positioning before ECMO. Almost 100% of them received prone positioning. And what was interesting is that compared to the EOLIA trial is that we use a lot prone positioning on ECMO. 81% of them were prone on ECMO. This was explained. One explanation is that most of them were quite fat and quite obese. Clearly we know that these patients are good responders to prone. And this is just example of how do we prone our ECMO patient. We use this kind of helmet. This kind of helmet are used in neurosurgery. So it's a good way. It's not so expensive. It's a good way to maintain well the tracheal tube, to be sure that the jugular cannula are secured. And by this way, you avoid pressure sore, especially when the patient had lots of prone positioning station. And by looking into the mirror, you can have a look what's going on around the mouth. So seeing if there is no plicature of the endotracheal tube. And for the procedure, we do it in routine now. So you have just one physician at the head, one physician on the feet of the patient. So the physician at the head will hold the cannula and the endotracheal tube with the same hand, and the physician or the healthcare giver at the feet will hold the cannula to make it loose. And this, the healthcare giver at the feet will guide it will be the chief of the maneuver, and it will guide the procedure. And then you have two persons on that side and two other persons on that side, and we do flip-flop like that, and we return the patient. So it's quite easy. You need to have 6 people, but it's quite easy, and we do prone positioning on ECMO for 16 hours, like it was previously demonstrated. Other difference between COVID-19 and EOLIA ECMO group is that you see that this patient bleed with the same rate, roughly 42% for the COVID-19, 46% with the EOLIA group. But what we can see is that pulmonary embolism was much more frequent in COVID-19 ECMO patient. And now, a few months later, we know that COVID-19 is a vascular disease with frequent thrombosis. So for that reason, we applied with COVID-19 ECMO patient, we target higher anticoagulation regimen. And but the price to pay if you use higher anticoagulation is, as you see, we had more frequent hemorrhagic stroke with terrible outcome. 5% of all patients had a hemorrhagic stroke in this COVID-19 cohort. Another thing is that number of ventilator-associated pneumonia was very high in COVID-19 patients, but the main explanation is the duration of mechanical ventilation, which was much higher in COVID-19 patients compared to other ARDS patients. So just a few words about the anticoagulation. So for classical non-COVID patient, so severe ARDS on ECMO, we use quite a low anticoagulation. We use on fraction heparin to a target APTT of 50 to 55 seconds, or we use anti-10A activity between 0.2 and 0.3. We don't use ACT to monitor on fraction heparin because ACT, it has been shown in many studies that ACT is not very reliable when you use low dose of heparin, and for non-COVID patient, we use quite a low dose of heparin because you are running your ECMO with a high flow, so the risk of thrombosis is quite low, but the risk of bleeding events are still very high. But for COVID-19, because it is still a vascular injury, with high risk of thrombosis, high risk of pulmonary embolism. So clearly we increase the target APTT of 60 to 75 seconds, or we use anti-10A activity between 0.3 and 0.5 for COVID-19 patients. It's quite interesting and important to use both tools to monitor your anticoagulation because APTT is frequently increased in naturally increased in COVID-19 patient because you have circulant anticoagulant in COVID-19 patients. So APTT might be sometimes not so reliable to monitor anticoagulation. Last difference between COVID-19 patient and earlier ECMO group, if you compare the duration of ECMO, it's almost twice with COVID-19 patients. So it was in median 20 days. So clearly the ECMO run, the ICU stay of this patient is going to be very long, and you need to expect that this patient will stay in the ICU for at least, let's say, more than a month. But at the end, if you are patient, if you take time, you see that the 60-day mortality was even a little bit lower compared to the earlier ECMO group. So clearly, I can't say that it was strictly lower, but at least it's the same. So at the conclusion, VV ECMO indication should not differ between COVID-19 patient and other patients with severe ARDS. But because your health system is overwhelmed, because you know that this patient will stay for a very long time in ICU and in hospital, you need to have a strict application of the EOLIA criteria. You need to use postponed positioning before ECMO. And clearly, because it's going to be long, there is a clear role of the experience and preparedness of the healthcare system, but I think this is quite well done in your country. And ECMO should be performed in experience center, obviously with clinical expertise. And at the end, if you apply that, you see that the survival of this patient is similar to that reported in study on ECMO support for severe ARDS published in the past few years. ECMO should be considered at an early stage for patients developing profound respiratory failure despite optimized conventional care, including prone position. And we are expecting, we are waiting for the result coming from larger database, ELSO, ECMO card, maybe you are involved in these databases. And but I'm quite sure that they will find almost the same result at the end. Thank you very much for your invitation. It was a real pleasure to do it.
Thank you, Professor, for that very informative and engaging lecture. So it must be overwhelming for most of us here, but it is interesting to know that critical COVID is not a death sentence in all patients.
No, clearly not.
Yes, we can now proceed with our Q&A. Please type in your questions in the Q&A box. And for those who are tuned in to Facebook, we will transmit your questions to Zoom, so don't worry. We'll be starting with the present questions. Our first question is, what is the preferred agent for volume resuscitation when patient is hooked to ECMO? Is it crystalloids or colloids, or is it wise to use Voluven?
No, we use we based on the most publication, we use crystalloid for ECMO patient, but for all patients in the ICU, except when you have a trauma patient with hemorrhagic shock, there is still room for using colloid, but clearly in the previous numerous publication, there is a high signal, a strong signal saying that you have more renal insufficiency with colloid compared to crystalloid. So we use crystalloid, it's even cheaper, and clearly it's at least efficient. All
right, so it's crystalloids. Another interesting question, maybe not for COVID, how do you manage ECMO in the special population like pregnant patients? Or were you able to manage pregnant patients with COVID-19?
Yes, we had one pregnant woman, but she was early in the pregnancy, and the fetus passed away. But for H1N1, for example, we had many women. For COVID-19, it was mainly men. For H1N1, it was more women, and especially pregnant women. So we cannulate this patient. There is two situations. If the gynecologist said that the patient, the baby is could live, you extract the baby and then you cannulate it. You cannulate the pregnant woman. If the pregnancy is too early and you need to wait for baby development, then you cannulate the patient with the baby inside, and we monitor the baby, and we see. We had some good experience with that, with patients who deliver after more than a month on ECMO with a normal baby.
Okay. Another question. I will be calling Dr. Dangilan. I think she has a live question. Dr. Dangilan.
Hi, Professor. Thank you so much for your talk. Huh? Yes, I'd like to ask if you use tocilizumab on your patients. And if you also do hemoperfusion. I'm a nephrologist, so those are my questions.
Sorry, I didn't hear properly.
Yes, Professor, do you give tocilizumab to your patients?
Okay.
Yes, and do you also do hemoperfusion, which is a technology to remove also other cytokines that are increased in patients with COVID? Thank you, Professor.
Okay. Yes, we had used tocilizumab, but it was mainly the patient were included in randomized controlled trial. So actually, there are no clear evidence for benefit for tocilizumab. Some study will be released soon, showing a non-benefit for tocilizumab. So what we use actually for the new COVID that we have actually in ICU, we use corticosteroids, dexamethasone, based on the recovery trial that was published by UK. And we don't use in routine cytokine absorption like cytosorb. We don't use it in routine. It has not
the benefit of this technique has not been clearly shown, so we don't use it in routine.
Dr. Schmidt, I have a question.
Yeah.
You use low tidal volumes for these patients. Do you encounter problems like atelectasis and mucus plug using lower tidal volumes may predispose these patients to atelectasis?
Yeah, this is an excellent question. What we use a low tidal volume because we know that tidal volume is harmful for the lung. But if you want to compensate the de-recruitment that will be induced by the low tidal volume, you need to increase your PEEP. And that's why we increase the PEEP on ECMO. So we decrease the tidal volume, but for most of the patients, we use a PEEP between 12 to 16 or 17, especially when you have obese patients. So to compensate the de-recruitment of the tidal volume, we increase the PEEP. But yes, there is a higher risk for atelectasis. That's why we increase the PEEP.
All right. We have another question here, Professor. Considering that the ventilator to ECMO days in your series is longer at 4 days compared with Eolia, which is 2 days, what explains the lower mortality in your series?
It's difficult to say that it's a lower mortality because, you know, we didn't do any tests to compare the 31% versus the 35. Maybe the same at the end. It's not statistically different. What we can say is that we reach quite the same mortality at the end. The difference of the number of days before cannulation is just because we strived to try prone positioning before ECMO. But I will not say that the mortality is lower compared to the Eolia trial because, as you say, 31% versus 35 is difficult to interpret, especially when you don't do any statistical test. So I will say that roughly we reach the same mortality at the end.
All right. Or maybe because you're a high volume hospital?
Maybe, probably it will impact. I'm clearly, yes, clearly the experience of the center, the volume impact the outcome at the end. But before being a large ECMO center, you need to start small at the beginning. So, so yes, experience impacts the outcome, like everything in ICU.
All right.
Dr. Schmidt, Professor,
Yeah.
another question, please. Do you have any more problems or any more complications or a better outcome using a double lumen cannula compared to a femoral jugular approach?
We don't use the double lumen cannula. It was a promising cannula at the beginning. We faced a couple of issues with this cannula. First of all, when the patient are very, very sick, very hypoxemic at the beginning, it's quite difficult sometimes to achieve a good oxygenation. And if you don't achieve a good oxygenation, it means that you will still rely on mechanical ventilation to ensure oxygenation and carboxylic dioxide removal. And at the end, you will lose one of the benefits of ECMO, which is to rest the lung. So we don't use so much double lumen cannula. Another thing is that, as you have seen, most of our patients are retrieved from other ICU. And it's very difficult when you are in the middle of nowhere because it's done on fluoroscopy or with TEE guidance, and it's much easier to put a femoral jugular for us. So a double lumen cannula, it's interesting for mobilizing the patient, but early on, at the early phase of ARDS, it might be disappointing for some patients. So we don't use it so much.
Professor, can I ask a question?
Yeah.
A practical question. We have problems with hospital-acquired pneumonia or ventilator-associated pneumonia. How do you prevent that? And do you get a lot of it in your patients, especially the ones who are very long on ECMO?
So yeah, this is a price to pay. You know that this patient is going to be ventilated for a month. So obviously, despite all measures that you will have ventilator-associated pneumonia. So what we do, we are very careful, but we are very concerned about this problem, and we try to early detect ventilator-associated pneumonia. Obviously, on ECMO, it's quite tricky because you have no fever. Chest X-ray, it's awful for this patient. You have a terrible bilateral lesion, so it's very difficult to see that there is something new and that you can suspect a ventilator-associated pneumonia. So as soon as you have an increase of the leukocyte count, for example, if you have a modification of the aspect of the tracheal secretion, we do a bronchoalveolar lavage. And but we clearly, these are not reliable tools to tell you if there is a ventilator-associated pneumonia or not. So we do frequent bronchoalveolar lavage and to try to early detect ventilator-associated pneumonia.
We have another question, Professor. Is there any outcome difference between double lumen cannula to the pulmonary artery versus two separate cannula in femoral and internal jugular routes?
No, I don't know any study which has compared these two strategies, especially for COVID-19. As I said before, we don't have a very large experience with this double lumen cannula in COVID-19 because these patients were so sick that it was tricky to achieve a good oxygenation with these patients.
All right.
Professor, how soon can you mobilize or initiate mobilizing these patients on ECMO? Can you do rehab for them? How soon?
Yeah, this is a dream to do rehabilitation, early rehabilitation. In fact, in clinical practice, it's not so easy. But we try to mobilize them inside in the bed. But you need first to be sure that your ECMO cannula are well secured. You need to have a physiotherapist. So what we do, we try to move them, passively move them. We try to awake them early. But with COVID-19, it was quite difficult because you have a very intense respiratory drive. So not so easy to awake them. So I can't tell you, I will say that after 8-10 days, we try to awake them, at least try to see are they awake, but it's not so easy. But in New York, for example, they mobilize them because they have heaps of physiotherapists. But for ARDS, it's much more complicated to mobilize them compared to a patient with chronic lung injury who are mobilized more easily.
Professor, I noticed that in your criteria for instituting ECMO, you use Murray score, like consideration of compliance, quadrants of X-rays involved in the infiltrates, and so forth?
Not much, because most of these patients have a Murray score, very high Murray score, so it's not so discriminant. We use the PEEP level of the patient before ECMO to be sure that the PEEP has been increased enough to improve the oxygenation. About the chest X-ray, they all have bilateral lung lesion involving the fourth quadrant, so it's not so discriminant. So we don't use much. We don't use a lot the Murray score.
Professor, do you have a lot of healthcare workers who got involved in ECMO who got COVID-19, or did they refuse to participate because they were scared?
No, yeah, we were lucky. We didn't see so many contamination. We have 2 or 3 health workers who had COVID-19, but it was impossible to prove that they got it in the ICU because in the ICU everyone has a PPE and we were quite well protected. So I think there is a higher risk to be contaminated outside the hospital compared to inside the hospital, at least in France for now.
So no special PPE for those doing ECMO?
No, same PPE, same. You need to, if you want to be effective, efficient, I think you have to do the same for everyone. And we manage ECMO patients like we manage all COVID-19 patients.
Universal precaution.
Yeah, yeah.
There's another question, Professor. Since you mentioned in your lecture that SARS-CoV-2 does not spread through ECMO or dialysis membranes. So for a COVID patient undergoing dialysis, do you need to designate a machine for the treatment of a COVID positive patient?
Yes, we try to, but it was maybe an excess of precaution early on in the crisis. But at the end, we had so many patients, so many COVID-19 patients. So at the end, we were not able to have a dedicated machine for COVID and for non-COVID patients. So I think there is almost no risk of contamination. Obviously, you will clean your machine like you clean your machine, like you usually clean your machine.
All right.
Professor, did you analyze your cases so that most cases needing ECMO were the L-type or the H-type pneumonia, or there were mention of all these two types of pneumonia?
Yes, no, this is interesting. This is one of the, it's on my to-do list for the next, we need to work on that inside the database. I think most of the patients were at H type with low compliance and probably with heavy lung. Most of them are H type, yeah, probably.
Okay. Do you have adolescents or younger patients with COVID and underwent ECMO?
Younger than what? Younger than?
Or maybe pediatric patients?
Pediatric, no. What we have seen 1 month after the peak of the outbreak, we have seen quite a large number of myocarditis involving young patients. When I say young, is younger than me, so it's teenager or a teenager or around 20. So this patient had a myocarditis. They all have a COVID-19 serology positive, but not with M immunoglobulin, but with G immunoglobulin, meaning that they had the COVID-19  1 month before. 1 month before. And they had a profound myocarditis. Some of them received VA ECMO for that. And they all respond very well to immunoglobulin. It was what was described by the pediatrician as a Kawasaki-like. So we thought that in young teenager or young adult or teenager. And the case series is in press in chest. It's going to be published in the coming weeks.
Okay. We have a question from Facebook regarding proning. Considering ECMO means long rest, is there advantage to really put on prone patients who are already on ECMO?
Yeah, sure. I do believe that because proning is probably one of the most efficient way to decrease ventilator-induced lung injury, because as soon as you will recruit more alveoli, the tidal volume will be shared by more alveoli. So the stress inside each alveoli will be decreased. So
it's one of the way to decrease ventilator-induced lung injury. So is it useful and benefit on ECMO? This is, there is an ongoing randomized control trial that we perform in our department, comparing proning on ECMO versus non-proning on ECMO. And we will see if it will speed up the weaning process. But there are good signals suggesting that it might be useful, yes.
Okay. We have another question from the chat box. Why is interleukin-6 correlated with survival, or how about the other cytokines?
Yeah, we didn't, this is a good question, interesting question, but we didn't dose interleukins in routine in our ECMO patient. So I can't answer to that question clearly, but it's a very good point.
Okay.
Professor, do you have an algorithm that you follow in weaning patients from ECMO?
Yes, yes, we have a weaning algorithm. I can send it to you if you want. It's gonna. I did a figure last week for a review for intensive care medicine. So yes, I can share it if you want.
And it's applicable. It's the same way that you wean for COVID patients and ARDS.
Yes, we apply exactly the same. Now, clearly, we didn't invent something new. We just apply what we know to do. Yes, we apply the same algorithm strategy, but for COVID-19, you need to be much more patient.
We have another question. In an open heart surgery, can ECMO be beneficial for those patients who are on the cardiopulmonary bypass for a long time already? I think this is not connected to COVID, but in general.
In general, can we do open?
In an open heart surgery, can ECMO be beneficial for those patients who are on the cardiopulmonary bypass for a long time? Maybe because
yes. In post-operative, we use it, but it's this is another way to do ECMO. It's mainly VA because it's cardiac failure after being out of the pump. So yes, post-operative ECMO are quite efficient with acceptable outcomes. It's roughly between 30 to 40% survival.
Or maybe,
Professor, can I ask a question, JK?
Yes.
Professor, your data shows a lot of patients with pulmonary embolism, which we know in COVID is very high. How do you diagnose pulmonary embolism? Do you let your patients undergo a ventilation perfusion scan, or what procedure do you do?
We do thorax angiogram, CT scan. We do CT scan. Or sometime when the pulmonary embolism was massive with TEE, it was a TEE or TOE. It was enough to make the diagnosis.
Thank you.
Professor? Professor?
Yes?
There's a question from Japan, and this comes from Dr. Ishiba.
Okay, my friend, Dr. Ishiba, yes.
Did you try steroids before, during ECMO, and what was the outcome? What benefits have you seen?
Yeah, so clearly it depends. Before the recovery trial, we didn't use steroids in routine in COVID-19 patients. Okay, after the recovery trial published from UK, published in the New England Journal of Medicine in July, now we use dexamethasone for all COVID-19 patients to avoid deterioration. But for quite a large number of patients, we use corticosteroids when you have no improvement after 3 weeks or 4 weeks, like it was done in the Medury trial. So we use a high dose of corticosteroids
prevent and to avoid fibrosis lesions. And so we use late corticosteroid for that patient at the end.
Professor, from our nephrologist, do you also do CRRT in ECMO? And do you connect the CRRT line to the ECMO line, or do you have another line? And do you do citrate or heparin anticoagulation for CRRT?
Okay, now for CRRT, we do heparin, we don't do citrate. For VV, when you have very high flow, it might be tricky to connect the CRRT on the ECMO device. For the COVID, during the COVID-19 outbreak, and for most of the severe ARDS patients, they have high ECMO flow, so we use dedicated catheter. But for VA, for example, we use CRRT on the ECMO machine, and it works pretty well.
Professor, at what point do you terminate ECMO in ARDS patients and among those who had COVID? Did you have come to a point where you had to terminate ECMO?
Yes, when you think that ECMO it's a bridge to nowhere, when you have no hope of recovery, but as soon as your patient has only lung failure, if you have no additional extrapulmonary dysfunction, I think there is still hope for recovery. So we don't have strict criteria because it's based on it will depend from one patient to another, but it's a very difficult discussion with all the healthcare team, with the family, sometimes even with the patient when he's conscious. But we clearly it's ethical dilemma which raise with the ECMO. So I cannot give you a formal strict criteria, but obviously if you have multiple organ failure after 3-4 weeks on VV ECMO, clearly it's going to be probably the right time to terminate ECMO. But as soon as you have only ECMO involvement, and if you don't have so much fibrosis on the CT scan, it is probably worth to continue and to be patient.
Professor, we have another question because many doctors are now interested in proning. What sedative agent do you use if you prone patient on ECMO?
For the sedative?
Yes.
Yeah, we use what we currently use. So we use a mix between sulfentanyl, propofol, midazolam, and frequently and most of the time when the patient is prone, he is on neuromuscular blockade.
Okay, just a follow-up question. How many days do you give your neuromuscular blockade?
We try to stop neuromuscular blockades as soon as we can. So during the ARDS, early on in the ARDS phase, we give 48 hours of neuromuscular blockades. But after these 48 hours, we try to stop it. If the patient doesn't need it because he's well adapted with the ventilators, there is no point to continue it. But it's clearly we check it every day if we can stop the neuromuscular blockade.
How about sedation holiday, Professor?
About sedation holiday?
Yes, do you do sedation holidays?
What, you mean stopping sedation?
Yes, yes.
Okay. Yes, we stop sedation almost every day. Depends. Every day. First of all, it's to have a neurological evaluation, because as you have seen, brain damage and brain hemorrhage are quite frequent, even if it's only 5%, but it's not so easy to detect it. So by trying to awake the patient, it might be useful. So we try to stop the sedation almost every day, and it will be based on the tolerance of the patient. If you
if you see that the respiratory rate is very high, or because the ventilatory drive is still too high, you need to resedate the patient.
Professor, there's a question. Do you encounter RV problems with low tidal volumes?
RV problem, right ventricular issue?
Right ventricle.
No, not much. We saw RV issue before ECMO. Yes, ECMO, before ECMO, you have RV dysfunction in most of the patients because the intrathoracic pressure is so high that you have RV dysfunction. But on ECMO, we don't see much RV dysfunction. No, not so much. If you have RV dysfunction on ECMO, it means maybe that you have pulmonary embolism. So it might be a way to detect it.
Professor, you showed us that many patients with a long time on ECMO, they develop pulmonary fibrosis. And I'd like to ask about your patients who actually survived, especially those who were on ECMO for a long time. Do you find chronic sequelae? Do they develop some kind of restriction of their lung function? What are you seeing?
Yeah, this is no, clearly is the new question is that say how will they be at the end about the survivors? So we are following up this patient with doing a test function, with doing CT scan, and you would have been surprised to see the CT scan of some of them. Some of them had normal CT scan 3 or 4 months after it. So the potential for healing of the lung is magical. So yes, some of them have a little bit of restriction, but actually this is in process. So maybe I will tell you more about in 6 months or yeah, at least 6 months.
Professor, do you have problems with blood pressure when patients are placed on proning, or does their blood pressure go down?
Not much, not much. Sometimes, yes, sometimes, but not much.
Okay, last two questions, Professor. How about pneumothorax? How often do you see pneumothorax in your patients?
So pneumothorax, it's less than 10% of our patient. If you markedly decrease mechanical ventilation ECMO, you will reduce the risk of pneumothorax. But it's still a risk, yes.
Okay. How about myopathy? Because some patients are on steroids and neuromuscular blockades. Do you see myopathy?
Yeah, yes, they have myopathy, they have neuromyopathy, they have such a long stay in ICU, in the bed, and as you said, with steroids, with neuromuscular blockade. So yes, that's why you expect a very long hospital ICU stay. And but after, because they are young patients, so with rehabilitation they will recover quite quickly. When I say quickly, it's at least a few months, but it's nothing compared to life.
All right. Maybe for our last question, is your PTT target for pulmonary embolism on ECMO is same with COVID patients?
Yes, yes. When we detect pulmonary embolism, we target a PTT at 2.5, so a little bit higher than what we did for COVID-19 patient when you have no pulmonary embolism. So clearly we are targeting a curative anticoagulation regime.
Oh, it's the same. Okay.
One last, Dr. JK. Professor, there's a question here, I think maybe from a nephrologist. Do we change blood flow or duration of dialysis on patients on ECMO?
Do we change?
Yes. Any change for the way that dialysis is being done once patients are on ECMO? Or
no. If the patient is stabilized hemodynamically, we do discontinuated renal replacement therapy. If you have still hemodynamic instability, you do continuous renal replacement therapy.
you have any problems with volume, especially patients on ECMO and on dialysis? Because sometimes we see patients having a lot of chattering, and it's very difficult to balance
Yeah.
the two.
Sometimes, especially at the early phase of ARDS, when you have hemodynamic instability, it could be tricky during the first day. So we increase slowly the flow. The flow on the CRT are increased very slowly to try to make it more smooth, and by this way the patient can tolerate it.
All right. Promise, Professor, this will be the last question. We know you're very tired of answering our questions. From our nutritionist, any role of IV fish oil among COVID patients on ECMO?
No, I don't know. Maybe you have to try it. It's your next trial. No, I don't know.
Thank you, Professor. Thank you for all your questions and comments. Thank you, Professor, for patiently answering our queries. So to formally end today's webinar, may I call on the Deputy Director for Medical Education of the National Kidney and Transplant Institute, Dr. Romina A. Dangilan.
On behalf of the National Kidney and Transplant Institute, we would like to thank Professor Schmidt for sharing his vast expertise on ECMO in the time of the COVID pandemic. It inspires us all to do ECMO in our patients who are critically ill with acute lung injury, not improved with maximal mechanical ventilation. For those who are interested in learning more about ECMO, do write Dr. Chavez and Dr. Hinete for training modules. The NKTI continues to look for advanced technologies in the treatment of the critically ill patient with lung failure, kidney and liver failure. There are some who are concerned about the challenge of offering such a high resource requiring technology for the Filipino patient, and that it may deprive other treatments from other patients. We take this as a challenge in a government hospital setting. We believe that resources should be provided for acute organ injury, such as COVID, as these patients recover, and in certain diseases, recovery is complete and fully reversible, like Dr. Schmidt showed us in his patients. Maybe after 6 months, he will have better information about any chronic sequelae. And for these patients who have chronic effects on their lungs, then for sure close follow-up will be needed. I'd like to congratulate Dr. Chavez, Dr. Hinete. There are people behind the scenes, Dr. Mara Padillo, Dr. Remy Beroya, and other members of the ECMO team for organizing this webinar. And we are really deeply grateful to Professor Schmidt. We look forward, Professor, to welcoming you personally to the Philippines in better times. As a reminder to our audience, please complete the evaluation tool at the end of this webinar. Good day and good evening to everyone. Thank you so much.
Thank you very much.
Thank you, Dr. Dangilan. That is all the time we have for our webinar today. To all our panelists, thank you for joining us. Again, you will be directed to a post-webinar evaluation form. Please take a moment to fill out our exit survey right after this, or you can also scan the QR code flashed on your screen. Those who have completed the feedback form will be receiving their certificate of attendance through email. Professor Schmidt, we are sincerely grateful for sharing your precious time with us. We know you're very busy. Thank you for your goodwill. We hope to see you again, whether virtually or maybe on the next LSOC conference.
Yes.
Thank you.
That's cool.
Thank you, everyone. Have a good day.
Merci.
Please be safe.
Thank you. Merci beaucoup. Bye-bye.
Merci beaucoup.
Bye-bye.